stream. Okay, and we are live. Good afternoon, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Rudrani Banik. She's a neuro-ophthalmologist. As always, please remember the Google form will be posted in the chat box and in our Instagram bio at the end of the session. With that being said, Dr. Banik, you can get started whenever you're ready.
Well, thank you so much. I wanted to first thank the web shadowers for inviting me to participate in this wonderful program, and also Sophia for organizing the Zoom call. So today I'm going to be talking about what I love, my passion, which is ophthalmology and neuro-ophthalmology. So let's get started. Let's see here, a moment. All right. So as I mentioned, I am an ophthalmologist, and what that means is I am a physician that takes care of all kinds of eye diseases. For those of you who aren't familiar, ophthalmology requires, in terms of training, so after medical school, you do 1 year of internship, and that internship can be either in internal medicine or surgery or a transitional year. And then you do 3 years of ophthalmology residency. And during those 3 years, you basically learn the entire spectrum of eye care, from prescribing glasses to treating ocular surface disease to more advanced types of treatments like lasers and surgeries and so forth. And then after that 3 years of residency, there's an option to do a fellowship. And so I did a fellowship in neuro-ophthalmology. So I'm going to talk a little bit about that as well. A lot of people ask me, why did you decide to do ophthalmology? And it was, many reasons, but basically, I fell in love with the eye. I mean, it's such a small organ, but it has so many different components. And this is just kind of a cross section of the eye. So you can see that there's the front of the eye, there's the cornea, there's the anterior chamber. The iris is the colored part of the eye. Then we have the lens behind the iris that helps us to focus. And then behind that, we have the vitreous body. Back here is the retina, which is the layer that helps us to actually capture light images and process those light images and send electrical signals through the optic nerve all the way to the brain. So during ophthalmology training, you basically learn everything there is about this, this small organ that's so complex. And I think it's been estimated that there are about 40 different structures associated with the eye. So there's a lot to learn. It gets jam-packed into those 3 years of training in the US. And in terms of, the bread and butter types of things we see, I mentioned earlier, the basic eye conditions like, refractive correction, where we learn how to prescribe glasses, prescribe contacts, perhaps even do refractive surgery like LASIK or PRK. So that's incorporated within ophthalmology residency. We treat dry eye, ocular allergies, meibomian gland dysfunction, which is dysfunction of the glands along the lids that provide the oily layer to our eyes. We also treat conditions that cause vision loss. For example, the top 4 leading causes of vision loss in the world are cataract, glaucoma, diabetic retinopathy, and macular degeneration. So we learn how to do all of that and so much more. The other thing I really wanted to make a point about is that the eye, even though it's a small organ, it is very intimately connected with the rest of the body. So the health of the rest of the body is reflected in the eye. So a lot of people say, the eye is a window to our soul. It's really true that the eye is a window to our overall health. So for example, if someone has diabetes, then and their blood sugar is not well controlled, they may have eye complications. They may have bleeding in the back of the eye or other issues. Sometimes it can even cause cataracts, a certain type of cataract in the eye. If they have autoimmune conditions, for example, rheumatoid arthritis or lupus, that can also cause manifestations in the eye. And then infections can also cause manifestations in the eye. For example, tuberculosis, Lyme disease, HIV, even coronavirus can have findings on an eye exam. So again, the eye is not in isolation. It's very closely related to the health of so many other organs, our immune system, our endocrine system, our cardiovascular system, even our gut is linked to the eye. So it's really fascinating. So I just wanted to share with you, this is one of the reasons why I fell in love with ophthalmology. So when I was in college, so in my senior year of college, I was shadowing many different types of doctors because I wasn't sure exactly which field I wanted to go into. So I was shadowing, for example, I shadowed a pediatrician, I shadowed a family physician, I shadowed an anesthesiologist, and one of our family friends was actually doing ophthalmology residency. So he said, well, you probably don't know much about the eye, so why don't you come with me one day and see what it's like to be an ophthalmologist? And you can just come to clinic with me, you can come to the operating room and just get a sense of what it's like, in an average day. So I said, sure, I'd love to do that. And this day literally changed the course of my life, because as soon as my eyes, no pun intended or pun intended, my eyes were open to the beauty of ophthalmology. I was hooked from that day forward. And this was again in my senior year of college. And I'm just going to show you this. So this is an example of cataract surgery. So this is a video that I'm going to show you. It's sped up. So normally cataract surgery takes about anywhere from 10 to 15 minutes to complete. So this video is just a little over a minute, but it kind of goes through the steps of cataract surgery, and it gives you a sense of the technicality of cataract surgery and really the delicacy of cataract surgery. So I'm going to play this for you, and hopefully it plays. Let's see here. So again, this is sped up, so I apologize. There's a lot of motion in it. I hope no one feels any dizziness or anything. So basically, this is all done under a microscope, and we insert tiny little instruments into the eye to go in there. And a cataract is basically an opacity inside the eye that we remove. So that yellowish white structure, that whitish area here, is the actual cataract. So we're removing it, and we're moving it with this probe is an ultrasound machine. So basically, we break this cataract up into lots of little pieces with ultrasound energy. So high energy sound waves. And then we remove those little pieces from the eye through a very, very small incision. It's about a 2.4 millimeter incision. And we remove those pieces, and then we use a vacuum to remove those pieces. And again, this is all done through this handpiece right here. And you can see that this handpiece, it's eating up basically all these little fragments of the cataract. So once that's removed, then there is a need to put something in the eye to help the person focus, because normally the lens, which becomes a cataract, helps us to focus. So once that's removed, we need to put an implant in to allow the person to be able to focus at distance, and perhaps even distance, intermediate range, and also up close. So you can see that the implant's going in here. This is a silicone implant, and it stays again inside the eye, basically where the natural lens would be, and it stays with the person for life. So if you were looking at someone who's had cataract surgery, you wouldn't be able to tell that they've had cataract surgery, because it's actually inside the eye, behind the iris, the colored part of the eye. And it's just really incredible technology that we have to allow us to restore people's sight. And once I saw this type of surgery, that one day I was talking about before, when I was shadowing my family friend, I was just completely enthralled with ophthalmology, and I have been ever since. So one piece of advice I would give you is, as you're going through your education and your training, especially once you get to medical school, you're going to be exposed to many different types of fields, and you just have to find the field that really gives you a sense of passion. You have to love it, because this is what you're going to be doing probably for the majority of your career, the rest of your life. So you really have to feel a strong passion and connection with that particular field, and because that will provide you with the satisfaction necessary to go forward and remain excited about it. So this was my introduction to ophthalmology. Now, I know there was a couple of questions here, and I'd like to answer them before I move on, because next I'm going to be talking about neuro-ophthalmology. So one of the questions was, is a procedure for getting glasses from an ophthalmologist the same as getting them from an optometrist? Yes. So ophthalmologists and optometrists, we are both eye care providers. The difference is that optometrists go to optometry school, which is for a 4-year program after undergraduate. education. So it's a 4-year program. Some programs, some optometry programs do require a residency, but the residency is usually only 1 year. And optometrists can prescribe glasses. They can provide primary eye care. They typically, depending on which state you're in, they do not do surgery. Again, that depends on the state, but the vast majority of states, optometrists do not do surgery. They may prescribe some basic medications, for example, some eye drops, but they typically don't prescribe the range of medications that ophthalmologists may prescribe when necessary. For example, sometimes people have inflammation in the eye and steroids are required. So an ophthalmologist would be best suited to treat that patient if they did require more intensive kind of medical and surgical care. Now, the second question is, how painful is cataract surgery? So this is a great question. When we do cataract surgery, there are different ways to do it, but most patients are awake during the procedure. They have some sedation, so they're, they have an IV and they get sedation through the IV. So they're a little bit sedated, but they're awake. They can talk. I prefer that my patients talk to me during cataract surgery. I don't want them to move their head, but they can talk to me and I try to calm them down. But in terms of anesthesia, what we use is, aside from the sedation, I use a topical drop initially to numb the eye. And then when we go inside the eye, I use an anesthetic inside the eye. And that basically prevents pain. And so patients may feel, pressure as we're working, but they should not feel any pain. Now, depending on the doctor and the complexity of the surgery, sometimes additional anesthesia is required. So some people may actually need to have an injection of an anesthetic material behind their eye. So this is done under sedation, where they get a needle put right here and they get what's called retrobulbar anesthesia to keep them comfortable during the case. Okay, so then the next question is, does the immune system attack the implant in the same way it attacks other types of implants? Wonderful question. So the good news is no. So the implant is basically, it's inert. It is sterile, first of all, but it also doesn't have, on the surface, it's again, an acrylic implant. Some implants are silicone, but most of them are acrylic. They do not mount an immune response. So they are inert once they're placed inside the eye, and the patient does not need to be on long-term immunosuppression. In the first few weeks after cataract surgery, we do use steroids to help decrease inflammation, but that's only usually for a couple of weeks, and then the patient's tapered off and they're not on any long-term steroids or other immunosuppressants after that. So great question. Okay, so I think that's it for the questions for now. So I will go on. Let's see here. We'll move on to the next slide. Oh, okay. So I mentioned earlier that I did a fellowship in neuro-ophthalmology. And, a lot of people ask me when I say I'm a neuro-ophthalmologist, they say, well, what is that? I never even knew that there was such a thing. So let me explain now what neuro-ophthalmology is and why I chose to pursue this field, because it is a subspecialty of ophthalmology. So neuro-ophthalmology, basically, as the term implies, it combines two fields. It combines neurology with ophthalmology. So basically, it bridges the two fields and it deals with all the connections between the eye and the brain. So a lot of people don't realize that we actually don't see with our eyes. Information is captured by the eye, light information is captured by the eye, transduced into electrical signals, and then sent via the optic nerve to the processing center in the back of the brain, the occipital cortex, and some of the accessory visual cortices actually process that information and allow us to see images, forms, shapes, colors, motion. So we do not see with our eyes, we see with our brain. And 30% of our brain is dedicated to our vision. And that's just mind-boggling. Again, no pun intended or pun intended. That 30% of our brain is devoted to vision, our visual centers. So the eye and the brain are very, very closely connected. Actually, the eye is a direct extension of the brain. So during embryology, if anyone's taken embryology before, you will know that the optic cup is a direct extension of the brain. And so there are many conditions that actually affect vision that are neurologic conditions, and that's what a neuro-ophthalmologist does. And the reason why I chose to pursue this subspecialty training is because when I was doing my residency, I had amazing training in so many different areas of ophthalmology: glaucoma, cataracts, retina, strabismus, which is misalignment of the eye. So I was learning all of that and learning the surgeries for all of those conditions. But one thing that I did not understand was neuro-ophthalmology. It was almost like the big black box in my ophthalmology education. And I did have some great teachers, and I had some professors, but it just did not click for me. And I felt very uncomfortable with my knowledge base in neuro-ophthalmology. And also so I wanted to pursue it more. I wanted to become more competent in neuro-ophthalmology. And so that was one of the reasons I did my fellowship in it. But another reason I did my fellowship in neuro-ophthalmology is because when I was in medical school, I was trying to decide between what field I should do. And yes, I loved ophthalmology, but I kept my options open and I explored other things. The other thing I really loved was neurology. And, I chose not to do neurology as a residency because I wanted to do more procedures. I wanted to do something more technical with my hands. So I chose ophthalmology because of that aspect of it. But I also always kept in the back of my mind, I love the neurology, the thought process behind neurology, it's problem solving, it's localization, it's brain science. I mean, it's fascinating. So, when I was deciding on what type of fellowship to do, now, not everyone does a fellowship after ophthalmology residency, but many people do. I was, really drawn to neuro-ophthalmology for these two reasons. So I did an extra year of training in neuro-ophthalmology. And now what I do is most of my practice is neuro-ophthalmology. I would say 80% of my practice is neuro-ophthalmology and 20% is general ophthalmology, meaning I take care of glasses and contacts and dry eye and cataracts and all of that. So it's a good balance. Because I get to do the surgical aspect of it still, and I get to do the more, I would say, cerebral or intellectual aspect as well. So I was mentioning before, about neuro-ophthalmology. I think I explained this pretty well, but just to show you kind of on an illustration here, here's the eye, and then this structure here, these are the optic nerves. So these optic nerves carry all that information from the retina back into the brain. And so there's something called the optic chiasm here. And then all that information is carried all the way back, really back to the occipital cortex, which is back here. So as a neuro-ophthalmologist, I take care of that entire pathway. All those pathways, actually, it's not just one pathway, there are multiple pathways. And so in terms of what specific types of conditions does a neuro-ophthalmologist take care of? Well, this is a short list. It goes on, but I'll just mention to you optic neuritis, which is inflammation of the optic nerve strokes, optic neuropathies, meaning toxic hereditary optic neuropathies. There's something called drusen, which falls under this category. Papilledema, which is swelling of the optic nerve from a brain issue, and we'll talk a little bit more about that. Double vision, migraines, headache syndromes, facial palsy, which is a Bell's palsy, facial spasms, facial or eye pain syndrome. So you can get the sense that there's a lot of connections between, again, neurology and ophthalmology here. And then unexplained vision loss is something else that I help manage as a neuro-ophthalmologist. Now, in terms of all the neurologic conditions that fall under neuro-ophthalmology, so multiple sclerosis, neuromyelitis optica spectrum disorder or disease, brain tumors that have vision problems, strokes that have vision problems, aneurysms, vascular malformations, something called idiopathic intracranial hypertension. And I'll explain more what that is in just a moment. Giant cell arteritis, which is an inflammatory condition that can affect the entire body. They can also affect the eyes. Thyroid eye disease, which is basically an autoimmune disease where there is thyroid dysfunction. There may or may not be thyroid dysfunction, but because of an immune response to the thyroid, the eye socket can get inflamed and cause swelling of the eyes, double vision, all kinds of other issues. And then myasthenia gravis, which is another autoimmune condition that can cause double vision and droopy eyelids, and many, many, many more conditions that are neurologic, but also have eye manifestation. So it's a very broad range of what I take care of. And it is fascinating because every patient comes in with a different type of symptom, a unique symptom, unique history. And it's really a matter of putting together the pieces to solve the puzzle. So it's really being a detective. And that's why I love neuro-ophthalmology so much, because it really is very intellectually stimulating. It's never the same day, never 2 days in a row are the same. No two patients are the same. So, if there are any questions, I'd be happy to answer them before I move on to, I'm going to do a case presentation. So we have about 40 minutes left. So I'll do a case presentation and then I'll take some questions for that as well. But do we have any questions right now? Okay, so besides neuro-ophthalmology, what are some fellowships that allow subspecialization in ophthalmology? So there is cornea and external disease, uveitis, retina, glaucoma, pediatrics, strabismus, refractive surgery. These are some of the fellowships, subspecialty fellowships in ophthalmology that are possible. There's also ocular oncology, so tumors of the eye. I'm probably missing one or two, but those are the main ones. Okay, so have you ever operated on a brain tumor? Yes, I have, and we're going to get to that. So I do operate. Right now, my practice is mainly limited to, I do mainly cataract surgeries, but in the past, I have operated with my neurosurgery colleagues, with my neurology, with my ENT colleagues on tumors of the eye socket and the brain. So yes, but it is not brain surgery. So what we do is not brain surgery. It's limited to the optic nerve pathway, not necessarily in the brain, because then we coordinate with our colleagues in neurosurgery for those types of cases. The next question, can you go into neuro-ophthalmology through the neurology residency path? Yes. So excellent question. There are two ways to do neuro-ophthalmology. You can do the ophthalmology pathway, which is what I did, or you can do neurology. And so for neurology, it is 4 years of neurology residency. There's no internship, it's all combined into 4 years. And then you would do neuro-ophthalmology fellowship after that. And most fellowships are 1 year. There are a couple of fellowships that are 2-year fellowships. So absolutely, you can approach neuro-ophthalmology through both aspects. If you do approach it through the neurology aspect, you will, most neurology trained neuro-ophthalmologists are not going to be doing some of the surgeries that that ophthalmology trained neuro-ophthalmologists do. Okay, so what is the difference between, sorry, I'm missing part of the question here. What are the differences between pediatric and adult ophthalmology? Great question. So there's definitely a lot of overlap, but in terms of pediatrics, pediatric ophthalmologists, they tend to focus on, again, pun intended, on first making sure that the child has correct glasses. And you may ask, how can we tell if a baby, for example, needs glasses, or a young child who can't necessarily, where we can't necessarily check vision. So that's all part of the training. We have techniques. We use certain types of eye drops to dilate the eyes. We use lenses to determine what the glasses prescription will be. So part of pediatric ophthalmology is that aspect of it. And then also a big portion of pediatric ophthalmology is when the eyes are not aligned properly, or if one eye is not seeing well compared to the other, that's something called amblyopia. And that's oftentimes, it begins in childhood, early childhood, and it needs to be diagnosed and treated early, because if it's not treated before the age of 10, then sometimes the vision, in most cases, the vision will not improve. So you want to diagnose and treat those cases before the age of 10. So again, figuring out what the glasses prescription is, alignment of the eyes is very important. And there are certain pediatric ophthalmic diseases as well that a pediatric ophthalmologist would treat. For example, congenital cataracts. Even babies can get cataracts, children can get cataracts. So that would, in most cases, that would be done by a pediatric ophthalmologist. So I think I'm going to move on now, just so I can get the case in. And then again, if there's any other questions, I'd be happy to answer them as I go along. So let's move on here. Let's see. All right, so this is the case. Again, this is a neuro-ophthalmic case. This is a 34-year-old woman who came in because she had longstanding migraine, but she had worsening headaches. And she also had something called tinnitus. Tinnitus is a ringing in the ears. And she had what's called pulse synchronous tinnitus. So basically what that means is every time her heart would beat, she would hear a whooshing sound in her ear. So like a whoosh, whoosh, whoosh kind of sound. So it's a little bit different than high-pitched tinnitus, which is like a buzzing sound. This is a very specific type of symptom. And she was having this new symptom for about 6 weeks. And in addition to that, she was otherwise doing pretty well. She did not have any vision changes, vision loss, blurry vision, double vision. But she did mention that over the past 6 months, she had had a 24-pound weight gain. So headaches, a tinnitus, which is again the swishing kind of tinnitus, and weight gain. And this is what the patient looked like. Now, this is posted with the patient's permission. So you can see that she's fairly young and she is overweight. So she was probably overweight to begin with, but she had a 24-pound weight gain recently. And so on exam, and I'm just going to briefly just shorten her exam just for the sake of time. We did an exam in the back of her eyes, and this is what the back of the eye looks like. This is called the fundoscopic exam, and this is done after dilating drops are put in. And we look at the optic nerve. So these are her optic nerves. This is the right eye, and this is the left eye. And many of you have probably never seen optic nerves before, but I'm going to show you what a normal optic nerve looks like. But what I'll tell you is that these optic nerves are not normal. They are swollen. So this kind of ring of fuzziness around the optic nerve is swelling of the optic nerve. So again, she's got swelling in the left eye, a little bit less, but she definitely has swelling in the right eye as well. And next, I'm going to show you what a normal optic nerve looks like. So here we have on the right is what a normal optic nerve would look like. So we have a very distinct kind of a border of the optic nerve, and this is called the optic disc also. And in the center of the optic nerve, we have a yellowish white area, and then the blood vessels coming out from the middle of the optic nerve, and these blood vessels go to the retina. So this is, again, very distinct borders, healthy, normal looking optic nerve. And you can see here that we do not see that. It's almost like this optic nerve is like a mushroom. There's a tremendous amount of swelling and everything's kind of been pushed up and out. It's almost like a mushroom cloud. You cannot make out the borders. You can kind of imagine that they're under here somewhere, but she also has this fuzziness, this kind of redness of the optic nerve, a lot more red than what it would normally be. So it suggests that she has congestion in the optic nerve. So whenever we see swelling of the optic nerve, especially if it's in both eyes, and we're concerned about a brain process, we get concerned about a condition called papilledema. And papilledema basically means that the optic disc or optic nerve head, also called the optic papilla, is swollen, and edema means swelling. So the concern is here papilledema. And whenever we see this in a patient, no matter who the patient is, whether it's an adult or a child, a man or a woman, no matter the age, this is a neurologic emergency. And the main reason why it's an emergency is because we want to make sure that this patient does not have a brain tumor, causing swelling of the optic nerves, causing her headaches, perhaps causing some of her other symptoms. So this patient needs to be scanned ASAP, meaning that they need either a CAT scan or an MRI, whatever's available first. Usually MRI is preferable, but depending on where you are, what the accessibility is, it may not be available. So CAT scan is sufficient. We need to scan the patient within 24 hours because we need to rule out a brain tumor, because a brain tumor can lead to something if it's advanced, and if it's really causing a lot of congestion and pressure in the brain, it can lead to what's called a herniation of the brain and possibly even death. So you need to diagnose this ASAP. And I'm just going to show you, this is not what the patient's scan looked like. I'm going to show you what her scan looked like in a moment, but I want to show you what a brain tumor would look like on a scan so you can kind of get a sense of what we're concerned about and why we're so concerned about it. So I hope this plays properly, but this is an MRI. And so I'm going to scroll through this MRI here, and you can start to see this big white area here. This is the brain tumor. So this is a type of benign brain tumor called a meningioma, and it's basically sitting right here, right behind the patient's forehead, basically sitting on top of the patient's optic nerves and extending into their sinuses. So this is, again, a very, very large brain tumor called a meningioma, and this is something that you absolutely need to rule out. That's why that scan is so, so important ASAP. Now I'll show you one other. I think I have just one other image here. So this is a different view on the same patient's MRI. Now, this is, again, not the patient I presented, but I just wanted to show you what a brain tumor would look like on a scan. So here you can see this is a very, very large tumor. And I'm going to scroll through here. I think I'm going to scroll through. Here we go. And I don't know if I go through all the way, but the eye sockets are in front of this tumor. So again, this is, again, about the size of an orange sitting inside the patient's brain. So as a neuro-ophthalmologist, I do see this, unfortunately, I wouldn't say fairly frequently, but it is something common that I see in my practice. So it is something that I take care of. So what did our patient's MRI look like? I'm going to show you in just a moment. So she did not have a brain tumor, luckily, but she actually had a normal scan. So this is what a normal MRI would look like for a patient. And this is what her scan looked like. She had, these are called the ventricles, and they're normal sizes. I don't have the full video to show you, but I can tell you that she had no brain tumor. So at least we've ruled out the most serious life-threatening condition. So now, the question is, you have this young woman who has these headaches, swishing in the ears, weight gain, and she has a normal scan. So what is the cause of her swelling of the optic nerves? Why are her optic nerves swollen? And so we're going to be talking about what her presumed diagnosis is, which is something called idiopathic intracranial hypertension. Now, you probably have never heard of this before, IIH. In the past, it used to be called pseudotumor cerebri. Pseudotumor, meaning that pseudo means fake. So fake tumor, cerebri means of the brain. So it's not a real tumor, but it behaves like a tumor, meaning it can cause headaches. It can cause swelling of the optic nerves. It can cause vision loss. It can cause some other neurologic symptoms. So again, the two terms are used interchangeably. There are some small differences between them, but idiopathic intracranial hypertension, pseudotumor cerebri, pretty much they're equivalent in most cases. So let me go on here, and we're going to be talking a little bit more about what this condition is, idiopathic intracranial hypertension. So it's a condition that tends to affect women, and women in their childbearing years. So usually between the ages of, let's say, 18 to about 45 or 50 or so. And in the general population, it's not so common. It's about 1 per 100,000 per year. But in women in that particular age group, it is much more common. So it's anywhere from 90 to 22.5 per 100,000 per year. The majority of people who have this condition are women. Over 90% of the patients who have this are women, and over 90% of them are obese, actually overweight and obese. So definitely weight plays a role. We're not exactly sure why weight plays a role, but it does play a major role in this condition. So I'm going to move on here. Let's see. So I wanted to, raise awareness of this condition because, again, most people probably have never heard of it, but there is a very close link between IIH and obesity. And I'm just going to show you some demographic data of the US, obesity prevalence rates in the US. So this is based off of CDC data, and I'm going to go through a couple of decades to show you how obesity has risen and why this is so concerning in today's day and age. So this is a map of the US from 1989, and basically the states are all color-coded, and so light blue represents less than 10% prevalence of obesity. The slightly darker blue is 10 to 14% obesity. So most states were either in the some blue range, and some states had no data. Again, this is 1989. And then 10 years later, according to census data, 10 years later, in 1999, you can see now most states are now in either the blue or the more advanced prevalence category. So most states are either 15 to 19%. Excuse me. A couple of states are less than 10%, but now a couple of states have gone into the 20 to 24% prevalence of obesity. And then 2008, so higher. Now you're starting to see some oranges and even some reds, which is very, very concerning. The reds are basically greater than 30% obesity prevalence, and only one state still has 15 to 19%. And then unfortunately, we don't have more recent data. So hopefully with the census that's going on right now, we'll be able to see exactly where the obesity rates are now. But my guess is that most states now are going to be in the orange or even dark red. And so so I do have this data, but I don't have the graph. So the average prevalence of obesity in the US is about 35.7%. So that's very, very concerning. And there are differences. This is New York State data from 2010. I happen to live in New York State, but there are differences in obesity prevalence based off of ethnicities. So white non-Hispanic 23%, Hispanic 26%, and Black non-Hispanic 35%. So there are racial differences in obesity prevalence. And so in terms of IIH, or going back to that condition I was telling you about, idiopathic intracranial hypertension, we definitely do see differences in ethnic groups. So definitely many of my patients, especially in New York City, where I live, many of my patients do happen to be Black or Hispanic, though there certainly are patients who are white, non-Hispanic with IIH, but the prevalence is higher in certain racial groups. So how do we make the diagnosis of IIH? Well, we use this criteria called the modified Dandy criteria, where patients have to have signs and symptoms of high pressure in the brain. And then we also have to do an MRI or CAT scan that shows that there's no tumor there. There's no other cause of high pressure in the brain. We need to make sure that they don't have any focal neurologic signs, meaning no evidence of stroke or other, weakness, numbness, nothing like that. And then also normal CSF, which is cerebrospinal fluid. So to make the diagnosis, this is very, very important. To confirm this diagnosis that there is high pressure in the brain, we need to do a spinal tap. And I know a lot of patients are very concerned about doing the spinal tap, but it is absolutely necessary, because one of the things we also want to rule out with the spinal tap is something like an infection like meningitis causing high pressure in the brain and swelling of the optic nerve. So that's why the spinal tap is so important. And we absolutely need to do this for our patients, even though many of them are very hesitant to get a spinal tap done. Let's move on here. So one other thing I wanted to point out, so I mentioned that we always get an MRI. Sometimes we also do something called an MRV, which is an MRI, but looking at the veins or the venous structures of the brain to see how the veins are draining. And sometimes what we'll see is, so this is an example of a patient who had an MRV done. And these are some of the main veins that drain the brain. So on one side, this is kind of the back of the brain over here. On one side, the vein is open, but the other side, it's not filling. It's not patent. It's not open. So this patient happens to have drainage only through one side, which about 20 to 30% of patients have, is one side doesn't drain at all, and all the blood is draining through the other side. But if you look here, you can see that there's it's not an even kind of outflow. There's a focal area where where it's very, very narrow. So this is something that we also look for in our patients that we suspect have IIH. We want to make sure that the veins in their brain are draining properly. So this patient has a focal obstruction of one of the veins here. And you can see this is a side view of the same patient. Again, this is not the patient I was presenting to you, but this is a patient with similar symptoms and findings on their exam. But this is a focal area where there's obstruction of outflow. Okay, so we're going to move on here. So what causes the swelling of the optic nerve? Well, this is, again, the healthy, normal-looking optic nerve, and this is a nerve that's quite swollen with papilledema. And this is a cross-section of what the optic nerve would look like. So imagine you took this nerve and you kind of looked at it from the side angle. And again, the nerve connects with the brain. So normally the nerve has a little depression in the middle. And then these fibers, these are actually nerve fibers that go and connect through the optic nerve back to the brain. But what happens is when you have pressure in the brain, again, the brain is directly connected to the optic nerve, that pressure gets transmitted to the optic nerve. And what happens is you get buildup of pressure. So you can see here in this diagram that there's actually congestion right behind the optic nerve. So there's buildup of pressure, and it basically pushes everything up, and it creates this mushroom effect. And you can see that instead of there being a nice depression in the optic nerve, now there's this big elevation of the optic nerve and congestion and again, swelling of the optic nerve that we call papilledema. So let's move on here. And what happens is with swelling of the optic nerve, it can cause vision loss. It can cause very specific types of vision loss, peripheral vision loss first, and then central vision loss. So if this goes untreated, people can actually lose vision. And there are, some rare cases, about 10% of people who have this condition, IIH, will end up with blindness. So this is something that we definitely want to diagnose and get treatment started on early, because we do not want our patients to go blind from something that is treatable. So early diagnosis and treatment are key. So someone asked, what is a spinal tap? And I'm going to be getting to that in just a moment. So I will answer that question. And someone also asked, can IIH be genetic? Yes, it can be genetic. There are definitely genetic, case series of, a parent has IIH and then their child has IIH, or perhaps another family member has IIH. Now, we actually, in a very large study that I participated in, we actually looked at the genetics of IIH. So we couldn't find specific genetic SNPs or short nucleotide polymorphisms that were associated with IIH, but we definitely know that there is a genetic preponderance or genetic risk. So a couple of other symptoms and signs of IIH I mentioned before: headaches, swishing in the ears. Some people can get double vision from something called the sixth nerve palsy, and I'll show you what this may look like. So this is a different patient with IIH, and you can see that her eye is turned inwards, it's not straight. And this is caused by high pressure in the brain, pushing on a nerve that's called the sixth nerve, giving her double vision. Now, fortunately, this is treatable. So once we treat the IIH, the double vision improves and the nerve palsy improves also. So again, what are the common signs or symptoms of IIH? So headache tends to be the number one symptom. 94% of patients will have headaches. TVO stands for transient vision obscuration. So basically, this is a transient loss of vision. Usually when someone bends over, so imagine that there's high pressure in the brain and someone bends over, there are changes that happen in the optic nerve, flow changes and so forth that can cause transient loss of vision, where the vision may go completely out, it may go gray or completely black for a few seconds, and then when the patient stands up again or they get up again, the vision slowly comes back. So this is called a transient visual obscuration, lasting seconds. It can happen in one eye or both eyes, but this is also a common symptom of raised pressure in the brain. The swishing in the ears, about 58% of people will have that symptom. Photopsias, which basically mean flashes of light. Now, I know many people probably experience flashes of light or floaters. These are slightly different, but people can have flashing lights with high pressure in the brain, about 54% of people, and then eye pain. Some people may actually feel pain or pressure behind the eye or in the eye socket with high pressure in the brain. And so I was talking to you before about papilledema. So there's actually a grading scale for papilledema, and I just wanted to just show you what different stages of papilledema look like, because it's not something that develops overnight. It's something that develops gradually over time, over days to weeks to months to years. So, so probably this patient had high pressure in her brain for quite some time. It's not something, again, that happened just all of a sudden like that. So there are 6 different stages of papilledema. So I'm going to go through what they look like on an eye exam. So this is grade 0. So again, this is a normal, healthy appearing optic nerve. So really no obvious swelling of the optic nerve, even though the patient may have high pressure in their brain. So that's grade 0. Now, grade 1 papilledema is when the nerve starts to look a little bit swollen. So it's almost like a C shape. It's not that the swelling goes around 360 degrees, but it's partial swelling. I like to call this like 270 degrees of swelling. And we start to see some congestion here also. But one border of the optic nerve remains flat. So that little part right there does not get swollen. These are just some different patients with grade 1 papilledema. So again, you can see kind of like a whitish halo around the nerve, or it doesn't go all the way around, but 270 degrees around the nerve. And here also, you have a halo here. And also wanted to point out that here in this particular patient, these blood vessels start to look very squiggly. They look very congested and tortuous. And this is a sign also that there's some congestion going on at the optic nerve from something going on in the brain. So these are all signs of congestion. So let's move on here. So grade 2 papilledema is when things get a little bit more congested and swollen. And here you have 360 degrees of swelling. So it goes all the way around. That's the halo around the optic nerve. Sometimes you can start to see some changes around the nerve as well. For example, this patient here, I'm sorry, this came out very dark in this picture, but this patient has a little bit of bleeding also around the optic nerve that can be seen in grade 2 papilledema. Grade 3 papilledema, so you can see that there definitely is more evidence of congestion here. And you can see that some of the vessels start to look a little bit blurred, so you can't really make them out as well. This patient has almost like an angry looking optic nerve with a lot of, these are actually small areas around the nerve. These are called cotton wool spots because they look like little puffs of cotton or cotton balls. But basically, they're kind of areas of the superficial axons here that have not gotten enough oxygen. So these are almost like mini infarcts. An infarct is an area where a nerve hasn't gotten enough, or a tissue hasn't gotten enough oxygen. So these are tiny, tiny little mini infarcts around the optic nerve. Now, fortunately, they tend to be reversible, doesn't cause necessarily permanent vision loss. And then that's grade 3 papilledema. Grade 4 is when it's really hard to make out any real structural landmarks on the optic nerve. You start to lose that central area. And again, it just looks a lot more congested and angry looking, especially this one. It almost looks like you really can't tell, the borders, the vessels at all. So this is grade 4 papilledema. And then finally, this is grade 5 papilledema, where really all the structures on the surface of the optic nerve are very, very indistinct. Now, the interesting thing is that, a lot of my students ask me, so does the grade of papilledema correspond with the pressure in the brain? And the answer is not necessarily. So someone can have a very elevated pressure in the brain, but only have mild papilledema, and other people can have kind of borderline pressure in the brain, but very, very severe papilledema. So we don't quite understand the exact mechanisms of how the pressure in the brain correlates exactly with the optic nerve appearance. So that's still a mystery to us, and hopefully we will better understand that in the future. But right now, it doesn't necessarily correlate. So I'm going to move on here. So I mentioned before that papilledema can cause vision loss, especially if it's untreated for some time. So usually the vision loss begins in the periphery. So people may not notice it. They may have some loss of their peripheral vision. So these are examples of visual field tests, so peripheral vision tests that we do. And so basically people may start to lose their peripheral vision, and then eventually it'll start to come in almost like tunnel vision, and it'll start to close down. So this is an example of someone who had grade 1 papilledema. So they have some mild vision loss in the periphery. Grade 2, it's a little bit more advanced. Grade 3, again, closing in. Grade 4, pretty, tunnel-like. And then grade 5, people end up with only a small area that they can see. So imagine going through life not being able to see except for this very, very small tunnel area window that's open to you. So that's why it's so important to get these patients diagnosed and treated early, because you do not want them to get to that advanced stage where all they have is this very, very small area that they can see. Sometimes that vision loss is reversible, but sometimes it's not reversible. So again, you want to catch them early in the course of disease. So I'm going to just stop here. Maybe I'll answer this question that just came up. Are the grades of papilledema typically clearly defined? No gray area between grades? So wonderful question. So no, they are not, they do not fit into very specific categories. So sometimes I'll see a patient and they're somewhere between a grade 1 and a grade 2. So I'll say grade 1 to 2, or sometimes they're somewhere between a 3 and a 4. So it's not that they fit exactly into each specific category, but you want to kind of grade it so that you know how aggressive do you want to be with the treatment. So it is important to grade the papilledema. And then also it's important for monitoring the patient, because once you start the patient on treatment, and I'm going to be talking about treatment in just a few minutes, you want to be able to serially examine them and see if there's been improvement. So that's why it's important to grade the papilledema. What causes tinnitus in IIH patients? So wonderful question. So if you remember back to that MRV study I showed you with the veins draining, and there was that one area in that patient's MRV that was very, very narrow. So what happens, the reason why a lot of patients with IIH have tinnitus or pulse synchronous tinnitus is that there's a lot of turbulence going on in the veins that drain the brain. And especially if there's narrowing, there's a lot of turbulence. So every time the blood is flowing down, draining, there's turbulence in that venous sinus, and it causes a swishing sound with the heartbeat, with the pulse. So that's why it's like a whoosh, 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 kind of like a water sound. And you really have to ask the patient very, very specifically, what do you hear? Do you hear something high-pitched, or do you hear something low-pitched? Do you hear something like water gushing? Because high-pitched tinnitus does not mean that there's high pressure in the brain. It's probably an inner ear problem. But a low-pitched water sound is very, very suspicious for high pressure in the brain. So great question there. Okay, so I think I'm going to move on. Again, feel free to keep asking questions, because it's best that I go through the questions as I'm going through the presentation. So the key is that you want to treat these patients early, because once they've gotten to a stage and enough damage has been done to the optic nerve from chronic swelling, the damage becomes irreversible. And eventually, if it's been untreated for a long time, about 5 to 10% of patients who have IIH who are not treated end up with atrophy, which basically means loss or damage, permanent damage. And usually the swelling goes away and all you see is this kind of whitish looking optic nerve. And basically what you're seeing here are lots of dead axons. And you do not want to let the patient get to the stage where they have irreversible vision loss. So someone had asked me earlier, what is a spinal tap? So I had mentioned that a spinal tap is necessary for the diagnosis of IIH. So basically what it is we want to measure what the pressure is in the brain. And the brain and the spinal cord are connected through a fluid compartment. They're connected, but there's also a fluid compartment around them. So the way we measure the pressure in the brain is actually by measuring the pressure of the fluid around the spinal cord, because that's the easiest way to measure the pressure in the brain, because otherwise we'd have to put a needle into the brain and measure it that way. So that's not very safe to do. It's not something we can do easily in an outpatient setting, but a spinal tap can be done in an outpatient setting. So basically the patient is numbed, and here you can see in this image here, we go in the lumbar area, usually L4, L5 in this area over here, and then a needle is inserted through the skin, and usually it's done by someone who's experienced in this, because obviously it's a delicate procedure. A needle is put in, and the pressure is measured, and you can see here that a needle is put in, and then some of the fluid, which is called the cerebrospinal fluid, is drained. And the pressure is measured, and then the fluid is collected in 4 different tubes, and we send those tubes off to the laboratory to check for infection, to check for inflammation, to check for cancer. So that's the other reason why it's important to get the spinal tap, again, to measure the pressure, but also to check for all of those other things. So for a normal person, meaning normal weight person, their pressure within their spinal fluid or cerebrospinal fluid in their brain is usually less than 200 millimeters of water. Now, in a person who is obese, their pressure is a little bit different, and it's usually less than 250. So we check the pressure in these patients that we suspect have IIH, and if their pressure is above 250, then that's your diagnosis. You've been able to confirm the diagnosis. Now, usually the patient is in, when we do this pressure check, when we do the spinal tap, they're lying down. Now, typically, they should be lying on their side, and this image is actually incorrect. Their legs should be extended, because anytime someone curls up into a ball, that increases their abdominal pressure, and it increases the venous pressure in their body, and it can increase the spinal fluid pressure as well. So you want to have their legs extended, and you want to have the patient relaxed when they're doing the spinal tap. And again, this is done under local anesthesia. All right, so now sometimes with patients who are obese, it's quite difficult to do the spinal tap, because there's a lot of soft tissue, and it may be hard to find exactly where to go within that, that L4, L5 space to put the needle in to get to the cerebrospinal fluid. So some of these patients do need to be done, the procedure needs to be done under X-ray guidance, so it's just called fluoroscopy. And we look at them under X-ray, so we know exactly where to go with the needle, so we don't have to keep sticking them, because again, it's not the most comfortable to have a spinal tap done, even though it is under sedation. So I wanted to mention that there are many different medical conditions that can cause high pressure in the brain, and these are just a couple of the different conditions: sleep apnea, Addison's disease, which is an endocrinologic disease, hypoparathyroidism, COPD, which is chronic obstructive pulmonary disease, heart failure, renal failure, iron deficiency. Certain medications can also lead to high pressure in the brain. So in our history, we always want to ask about all of these things to make sure that there's not a secondary cause for why the patient has high pressure in the brain. Now, I'm just going to skip through some of this, because we're just running out of time, and I do want to leave some time for questions. So now, in terms of treatment, how do we treat these patients? Well, there's a couple of different treatments. We can either do, we usually begin with medical treatment, and if medical treatment is not effective, then we'll do surgical treatment. And the treatment decisions are based on the degree of vision loss. So not necessarily headaches or the amount of swelling, the Friesen scale of papilledema, but how much vision have they lost? So we do a visual field test, again, to test their peripheral vision. And if we see that they have lost peripheral vision, depending on how much they've lost, we either start them on low dose treatment or high dose treatment, or we bring them up to high dose treatment. And we use medications. We use various types of medications. We use something called acetazolamide, which can decrease the fluid produced by the brain. Sometimes we use something called Lasix, which is a diuretic. We use other diuretics. And the most important thing, though, is weight loss. And we know that weight gain is a risk factor for IIH, but weight loss is also a very effective treatment for IIH. And studies have shown that if people can lose anywhere from 6 to 10% of their body weight, so not, a tremendous amount of weight, we're not asking people to lose, 50 to 100 pounds. So for example, if you have a 250-pound person, you ask them to lose 6 to 10% of their body weight, so anywhere between 20 to 25%, 20 to 25 pounds, that may be enough to make this go into remission. Okay, so again, if you have a 250-pound person, you ask them to slowly, decrease their body weight down to 225, that may make this go away. And I typically recommend doing a slow weight loss that's sustainable. So not a rapid weight loss. And I typically recommend that they shoot for about 2 to 3 pounds a month. So over the course of a year, they'll get to that, 24, 25 pounds that I typically recommend for that size person. Now, I do have a couple of patients here. Does spinal tap carry a risk of high infection? No, not a high risk of infection. It is a sterile procedure. How did you feel when you did your first surgery? I was extremely nervous, extremely nervous. When I did my first cataract surgery, it took me 3 hours. I mentioned before, usually cataract surgery now takes about 10 minutes, but my first surgery was 3 hours long. I was extremely nervous, but the patient ended up doing well. Why is the spinal tap specifically between those two lumbar bones? It's because when the patient is in that position on their side, there's actually more of a gap right there. And so it's a more accessible area to put a needle in between the L4, L5 space. Now, sometimes in a hospital setting or in a supervised setting, sometimes patients have cervical taps as well if there's an issue with getting to the lower back. This, of course, is much more risky if we do a cervical tap because there's a much higher risk of affecting the spinal cord. So we want to avoid that as much as possible. All right, so I think I'm going to stop there with my case because I do want to leave a little bit more time for questions, but I will end with just saying that. So this patient, she was treated with weight loss, and she did very, very well with weight loss. She lost about 30 pounds, and a lot of her swelling went away. Her papilledema resolved, but the medications were also used in conjunction with the weight loss. She was put on an acetazolamide and then eventually tapered off. And now she's doing really, really well with no headaches, no swelling of the optic nerves. Her vision is normal, and she's doing well. But also there is a risk when people lose weight, but then they regain weight, there is a risk that this could recur. So it's something really important to counsel patients on is sustainable weight loss. So very, very important. So I think I'm going to just stop there. Let me just see. I just want to just go a little bit further here. I did have a lot more, so I'm sorry I didn't have time to go through all of this in my presentation, but I will go through and, sorry. Oh, I lost my presentation there. So go back to this here. So just some last words on IIH. So our understanding of this syndrome has been evolving. There were some clinical trials that were done. There were more that were planned, but unfortunately, the funding was taken away for them. So there's a lot of unanswered questions about this. Specifically, why is it more prevalent in young women? Why is it more prevalent in people who gain weight or are obese? We still don't understand that. And what about the genetics? What exactly is the genetic association? So lots of unanswered questions, but we do know that we can definitely treat these patients as very effective to start them on weight loss plus medications and then moving on to surgeries if necessary. So I will end with that. And one other piece of advice I wanted to leave you, I gave some advice in the beginning of my talk, but I wanted to also leave you with the thought that physicians must be lifelong learners. And yes, there is a long road to becoming a physician. You have to go through many years of education. You have 4 years of undergraduate, 4 years of medical school, and then you have internship, residency, possibly fellowship. But during that process, you're learning. But even beyond that, you will continue to be learning. Learning does not end there. You are going to be learning for the rest of your life. And that's how you stay well informed, because medicine is constantly evolving. There's so much to know. You always need to be up on things and just incorporate new treatment modalities and new insights into your practice, and enjoy it, because it's really a wonderful road and very fulfilling path. So I wish you all the best in your future careers, if you choose medicine or you choose something else, whatever you end up doing. And I'm happy to answer questions. You can reach out to me through my email, which is here, info at my website, which is rudranibanikmd.com. If you want to find out more about what I do, you can also please visit my website. There's a lot of information there. I also have a lot of blogs on vision health and brain health that you may be interested. I talk a lot about nutrition also I didn't have a chance to talk about that today, but nutrition for vision health and brain health. And if you are in Instagram, I invite you all to follow me on Instagram. I do post a lot of helpful tips on Instagram, a lot of educational posts as well. And I do a weekly series called Neuro-ophthalmology Mini Grand Rounds, where I go through a case like what I just went through today, but I do it much, in a much shorter kind of a version. But I go through what some of the radiographic findings are, what some of the MRI CAT scan findings are, what some of the exam findings are, and lab findings. So I think if you do enjoy kind of being a detective with these medical cases, please follow me and feel free to reach out. And then one last thing I did want to also mention is that, so I also do pre-med consulting. So if any of you are interested, I do help students in terms of strengthening their medical school applications. And this includes advice on what types of courses to take, which coursework would best prepare you, whether it's science related or not science related, because there are many other areas of study that are also very helpful for going into medical school that perhaps you should think about during your undergraduate years, not just medicine, not just science or biology or chemistry. I also give advice on research opportunities, because research is important. If you're going into medical school, you do want to have at least some experience. So how can you find some of those opportunities, and how do you choose an opportunity if you have multiple options? How to really network well in terms of, just kind of navigating your way through this process, and gaining admission to medical school. And also it's important for your letters of recommendation. How are you going to network with your potential letter writers? The application, what types of things you should include in your application. And most importantly, I think your essay for, applying to medical school. What are some things that you really want to emphasize and spotlight in your, what you've done so far in your life, and how you can make yourself a stronger medical school applicant. So if you are interested in pre-med consulting, please contact me through my email, and I could provide you more information on that. I have an online course, but I also have private consulting I do as well. So I think I'll end there, and I will open it up to any other questions if you have any. So there was one other question here. What do you do when your patient is not willing to lose weight? This is a challenging one, because some people are quite happy with their weight and they do not want to lose weight. And in some cultures, actually, it is not something women want to do, women or men want to do. They think that they're very healthy at the weight that they're at. So in that situation, I do counsel them on, if they're not willing to lose weight, at least a low salt diet, because salt increases fluid retention, which can increase pressure in the brain, or at least we think can increase pressure in the brain. So that's one thing. And then for people who are not willing to lose weight, or who are not able to lose weight, and if medications are not working for them, in those patients, then surgery is really what's indicated, especially to protect their vision. So some of those patients do end up going down the surgery route for their treatment. Okay, any other questions? How did the patient get referred to you when she didn't present with any vision problems? So this is a great question. So many times these patients will, especially if they have no vision issues and they just have headaches, they will sometimes go to their local emergency department, and they show up there saying that they have these horrible headaches. And in the emergency department, hopefully someone takes an ophthalmoscope and takes a look at the back of their eyes and see that there's swelling of the optic nerves. So that's oftentimes how patients get referred to us through the emergency department, or perhaps they've gone to their primary care doctor who is helping them manage their migraines, and then they have worsening headaches, and then they get referred to an ophthalmologist because of potential for papilledema. Sometimes their neurologist sends them to us. to the neuro-ophthalmologist if there is, again, a history of migraine, but some change in their headaches, and the neurologist wants to make sure that there's no swelling of the optic nerves or any other concern for raised pressure in the brain. What does your typical workday look like? Okay, so my typical workday would be, so I've kind of evolved my practice over time, but I, when I'm in my office, I have a private practice, but I also do a lot of teaching at Mount Sinai Medical School. So when I'm in my office, I see patients. I start in the morning. I actually start a little bit later. I start around 10 a.m. because I do have a family, and I get my daughter ready for school, and I like to get to the office, have some time to just kind of settle in and be prepared. So I start at 10 a.m. and I usually see patients until about 6 or 7 p.m. And then afterwards, I do my charting afterwards and so forth, and patient phone calls and things like that. When I'm in the clinic, I work with residents and fellows. Again, I start in the morning. Usually I would start around 9 a.m. and then I'm in the clinic till about 6 p.m. and I see patients with the residents. I help guide them through neuro-ophthalmic patients and what to do and create a plan for their patients. When I'm operating, usually the day starts earlier. So usually when I'm in the OR, it starts at 7:30. So we're in the OR and we do a couple of cases. I don't do high volume surgery. I'm not that type of cataract surgeon. So I do just a couple of cases at a time. And I'm usually there for a couple of hours. And then after that, then, I do other things. I also do research. So that kind of gets built into my schedule. So usually when I'm in the clinic, I have some research patients scattered through there, and I have a research team that helps me coordinate the clinical trials that I'm working on. So they take care of that, and they book my research patients also. So I do a lot of different types of things. It really just depends on what day of the week it is. So I have certain days of the week when I'm in my private practice, certain days of the week when I'm in the clinic and research center, and other days when I'm operating. Okay, any other questions? Okay, so the next question is, do you have to be matched to ophthalmology? Is it a competitive field? Yes, so there is an ophthalmology match, and it's an early match through the SF Match program, the San Francisco Matching Program. And so in most cases, now I don't know about this year because of COVID, if the time frame is different, but usually applications have to be usually in the early fall, and the interview season is usually November to early December, and then the match happens in early January, and that's earlier than the regular match, which happens in March. So this is a surgical subspecialty, so the match is an earlier match, and it is competitive. It is quite competitive, actually. I used to be a residency program director for an ophthalmology program, and I will tell you, in that program, we had 2 positions per year, and we would get over 300 applications for 2 positions. So again, it is quite competitive, but there are ways to kind of make yourself a stronger candidate. There are things that should be done prior to applying for ophthalmology. So competitive, but not impossible. Okay, any other questions? Okay, so I would like to end there. I wanted to thank you all for participating, for shadowing today. And I know I gave you a lot of information, and I hope it was interesting, the case I presented, because it is a condition that I see very frequently as a neuro-ophthalmologist. This is the condition I see most of out of all the different conditions I mentioned to you, aside from migraine. Migraine and IIH are the 2 most common conditions I see as a neuro-ophthalmologist. If you have any questions, please feel free to reach out to me. And again, I wanted to thank Web Shadowers and Sophia for helping to organize this session. Thank you.
Thank you so much, Dr. Banik. This was a wonderful presentation. Everyone really enjoyed it, and it was so great to have you on talking about this. It was so interesting. For everyone watching, just a reminder that the Google form for your attendance has been posted in the chat. To get credit, you need to get a 50 out of 75 on it and provide a valid summary, just as a reminder. And that'll be open for another 30 minutes from now, so I'll close it at around 2:39 Eastern.